Good day. My name is Dr. Laban and I'm a psychiatrist at the Reproductive Mental Health Program in Surrey. And today we're talking about perinatal depression, the diagnosis of perinatal depression. I have with me Tammy Stott, who's our clinician in the program, and we're going to have a conversation about how to diagnose perinatal depression, and we hope that this will be a support for family doctors who are able to see these patients in their practice and then identify the mom who has postnatal depression.
Great, thank you. So, Dr. Levin, tell me, what is perinatal depression?
So perinatal depression is actually a major depression, as it is classified in the DSM-5, that occurs specifically in the postpartum period, which by definition is from birth to a year postpartum.
It's a big period of time. It's a lot longer than most people would think.
Yes. I think the other thing that's very interesting is that 50% of people who develop postpartum depression actually develop symptoms in the last trimester of the pregnancy. So it is a longer period than actual whole year. But it is definitely something that has two periods in which there's a peak. So initially when baby is born, which most people are aware of, there might be postpartum depression, but postpartum depression also happens between 5 and 7 months postpartum. So you might have a mom, for example, that did fine in the first 6 weeks and everyone thinks she's gone for the wellness check and everything is okay, and then the reality hits in of becoming a mom and living with the new baby, and usually around 5 to 7 months mom can also develop a major depressive episode. And why that's important is because it's not always identifiable, because it presents with more irritability and rage rather than sadness. And some of it is about returning to work, the anxiety of leaving their newborn baby and going back to work. So it's important to have sort of a high index of suspicion for a mom who comes to you 6 months postpartum and says, I have these symptoms of depression or irritability or rage, because that might be a postpartum depression.
What about anxiety?
Anxiety is a big part of postpartum depression, and sometimes it's easy to be just, I suppose, dismissive of it because you think this is a new mom, she's meant to be anxious. And I think the challenge with depression is that you have an agitated depression. So it's a major depression that presents with agitation. So that mom can appear to be excitable and anxious. And so looking at them, they might not look like they're depressed, but the agitation is the manifestation of a depression in them. So the difficulty with postpartum depression is the diagnosis is not always easy because it's not the typical major depression. So although we make the diagnosis of a major depression with a postpartum onset, these moms don't present with the DSM-5 criteria of depression, so they're not always easily identifiable. So, for example, most family doctors will know that if someone has a depressed mood or sadness or lost interest in activities for a period, then they have a depressive process. Whereas with the postpartum mom, they are sleep deprived, have just delivered a baby, have the fatigue, changes in appetite and sleep, energy levels that are all related to the delivery and the postpartum period. So a family doctor can't rely on those kind of symptoms to say, okay, this mom's depressed. And so in those patients, we always say, when you're talking to the mom with postpartum depression, just assess her attitude towards the baby. Because someone who has negative thoughts about their baby, about their ability to be a mom, about the future that they can see for themselves and their baby, is a depressed mom. So she might not say to you, I'm sad, or I've lost interest in everything. She might actually say, I can't leave my baby, I'm with my baby all the time. She might say all of that to you, but then if you ask her, are you a good mom? She's going to say, no, I'm a hopeless mom. I'm failing at being a mom. And that's a mom that you need to worry about.
Right. And you talked about that first peak that's initially in the postpartum. So what would differentiate the baby blues versus postpartum depression?
So I think it's important to know that the incidence of postpartum blues is pretty high.
Mm-hmm.
So probably in most communities it's around 80%. And so it means that you can forewarn your mom to be in the pregnancy that most likely she's going to be emotional, she's going to be irrational, she might even be unreasonable and not sleeping, and you can forewarn her partner that the same is going to occur, but that's usually for the first week after delivery of the baby. And that is not a mom who has postpartum depression. That is usually the hormonal change that occurs postpartum, as well as the sleep change. So it's more a postpartum adjustment than anything else. And the blues is regarded as an organic kind of syndrome because of the hormonal change. So that's why it happened in such a high incidence. And so the postpartum depression mom is different because their depressive symptoms continue after that first week and sometimes become more and more pronounced 2 weeks after delivery or a month after delivery or at the 6-week visit. That's when they sort of picked up. The incidence of postpartum depression is 10 to 15%. So it's similar to the incidence of major depression in the general population. That's why it's classified as a major depression postpartum onset.
Okay. So what would be the risk factors then that would make it more likely that someone would experience postpartum depression?
So there's a lot of research out there about postpartum depression, and for every study that says this is a risk factor, there's one that says it's not proven. A lot of those studies were flawed, so the data is not accurate, and it's over many, many decades that this data has been studied. I think the single most important predictive factor is the lack of a partner support. That has consistently been the situation that we found from a sort of psychological point of view that will cause someone to have a postnatal depression. I think for understanding about postnatal depression is that the postnatal reality is very different from the antenatal expectation. And that's what actually leads to the depression. So your at-risk mom is your mom who didn't plan for a lot of the things that happen at the delivery, for example. Like she thought she's going to deliver normally, that her baby was going to come at term, that she's going to breastfeed her baby, and then she ends up delivering early, baby goes to NICU, she has a C-section, and she can't breastfeed.
Right.
So that's your mom that becomes sort of more at risk. About 60% of women who actually develop major depression develop their first episode postpartum. So women are definitely at risk for postpartum depression if they have a family history of depression, or if they have a mom who had postpartum depression, they're more at risk. And then if the mom has had postpartum depression before, there's a 70% chance that she'll have postpartum depression again. So it's a recurrent disorder. So the mom that you would consider to be at risk is a mom who doesn't have support, a mom who has had complications in the pregnancy that are going to probably lead to a different trajectory postpartum than she thought she would have, and a mom that has had depression before, in postpartum, or has a family history of depression. Mm-hmm. There are other variables like medical comorbidity. So if there's thyroid problems in the pregnancy, anemia, gestational diabetes, that can also predispose a mom to developing postnatal depression. And then the use of substances is the other big one that we see, where moms use substances to manage their anxiety in the pregnancy, and they end up having a postpartum depression.
Right. And a lot of the research that I've read too around support was there's a difference between lack of support and lack of perceived support, right? What the women perceive as the support from their partners.
Yes, and I think that a lot of it has to do with perspective, because people are raised differently in families. And so you will have a dad, for example, that says, my mom did everything, so my wife should be able to do everything. Right. And his wife probably came from a home in which that wasn't the case. She had a dad who did as much as her mom did. So it's often those kind of conversations that need to happen during a pregnancy. Yes. The communication around that would help prevent the postpartum depression in a mom. I think the role change is huge for a lot of moms, because they end up now having to take care of another person other than themselves, They also see that their husband's affections are not shared with the baby, and that's also a difficult adjustment to make. And especially if they feel anxious, they feel inadequate as a mom, and so when they're looking after their baby, they feel like their husband's sort of judging them in a comment, as in saying like, why don't you let my mom do that or show you how to do that. They can take that quite negatively because they're very emotional in the blues period, and they're very anxious, and then they feel indecisive because of the anxiety. That makes them feel less confident with the baby, and that leads them to think, I'm not a good mom. That's the start of the postpartum depression.
Right. So when the woman is in their GP's office, and whether they're there for themselves or their baby, at what point could the GP recognize the symptoms of, let's say, a mild to moderate perinatal depression that they can manage themselves, and at what point does it reach severe, and when should they reach out to us?
So I think that when a woman is pregnant, I think it's one of the considerations a family doctor should make. We have the Edinburgh Postnatal Depression Scale, which is a very valuable rating scale for a family doctor. So most family doctors are used to using the GAD-7 or the PHQ-9 to assess primary care level depression or anxiety. For the pregnant mom, the EPDS helps us do pretty much the same thing. And I think if a mom has checked off item 10 on the EPDS, which is about self-harm or self-harm thoughts, that's a mom that needs to be referred straight away to us. If a mom has got anxiety during the pregnancy, and the family doctor is able to use counseling techniques and self-care to help them manage the anxiety, that's someone that they can talk to about postnatal depression, prevention of postnatal depression, and they can do the assessment postpartum and at the 6-week visit. And those are moms that they can manage quite effectively with some understanding on what we use postpartum for moms who are depressed, and about medications and breastfeeding. The mom who is severely depressed is the mom that is detached from their baby. The mom that has feelings of wanting to self-harm, or the mom that feels that they want to disappear. And I think the important thing to understand is that transition from mild and moderate to severe can happen overnight. So if a mom has a family history of depression, if a mom has had past histories of depression or treatment for depression, if a mom has had traumatic events during the pregnancy or postpartum, that's a mom that needs to get referred to us, because that's a mom that's more likely than not to develop the severe postpartum depression. Postpartum psychosis actually presents very early in the postpartum period. So it's important to understand that the postpartum psychosis is going to happen 48 to 72 hours after, and it's going to be a mom that's very emotionally labile, almost manic or hypomanic or irritable in their presentation, pressured in their speech, and hearing voices and having delusional thinking around the baby. Moms who are severely depressed will present later on in the postpartum period, and they may have what we call mood congruent psychotic symptoms. So they will have thoughts of feeling sad or feeling emotional or inadequate as a mom, and then they will have thoughts that say, you are bad, or you are negative as a mom, or you are a failure as a mom. They will hear those, what we call soft hallucinations, which are part of the depression process. So if a family doctor is seeing a mom and the depression's getting worse, and then the mom is saying to them, like, I wake up and I have these thoughts that are coming into my head, or I hear these voices calling my name, these voices saying to me, you're a failure, that's a mom, the depression's getting worse. That's not a mom with postpartum psychosis.
So what's the incidence of postpartum psychosis?
It's less than 1% in this population. So it's generally a mom with a strong family history of psychotic disorders. So someone with a history of schizophrenia or bipolar disorder in the family. Psychosis, postpartum psychosis, the commonest presentation is usually mania, because bipolar disorder presents for the first time postpartum, and if a mom has bipolar disorder or a family history of bipolar disorder, the most vulnerable period for a manic episode is postpartum. So that's a mom that has to be referred during the pregnancy to our program for us to monitor them through the pregnancy to prevent the manic episode from happening. Schizophrenia can present postpartum for the first time, but it's in a very low percentage of presentation. And again, it's flooded psychotic symptoms. Like, it's something that's very identifiable. It's not subtle.
Right.
The mom that develops it subtly is a mom that has depression, and then the psychotic symptoms sort of emerge. There is a percentage of patients who have a severe depression that have those psychotic symptoms that will go on to develop schizoaffective disorder, but that is something that we do retrospectively, looking at the duration of the illness thereafter.
So tell me, what is it that's so important then about identifying perinatal depression and initiating treatment if necessary?
So I think that, because there is so much information out there about postpartum depression and the blues, there's lots of celebrities that have had postpartum depression, the media's focused on it, there's Facebook groups on it, there's a lot of misinformation.
Right.
And I think that it works negatively in different ways. One is a mom can think that she has postpartum depression and she doesn't. And the mom who does have postpartum depression is not going to be part of any of that and know any of that. Mm-hmm. The consequences for postpartum depression are significant because, as I said, 60% of women who have major depression have their first episode postpartum. Mm-hmm. So if you can identify a mom and prevent the postpartum depression, you're actually preventing someone from developing major depression as an illness. And major depression is treatable, but it's recurrent. 60% of people who have major depression will have another episode at some point in their life, even if they are compliant with medication. The second part of it is that this is a very important time for the mom and her baby. Everyone around her is happy, and she's not able to feel any joy, and she's not able to bond with her baby. And so what happens is it sets up the maternal child bond for failure, attachment failure, and that is a huge challenge going forward for children born in that sort of situation who fail to attach at birth. They develop problems with attachment, or even interpersonal relationships, may end up with personality disorders or substance use later on. So prevention of postpartum depression at birth actually improves mental health in a community long term. If we want to reduce the incidence of mental health issues in children and in adolescents, we start in pregnancy and make sure that that maternal-child bond has the best possible chance. The other thing is that children who are born to moms who have postpartum depression, who are not identified and not treated, end up having significant cognitive problems by the time they get to preschool. Mm. And moms who have perinatal depression, who are treated on antidepressants, their children do so much better cognitively at age 5. There is a lot of misinformation around treatment of postpartum depression that family doctors can help a mom who is distressed navigate, so that she can explain to her husband why she needs to be on medication, explain to the pharmacist why she needs to take this medication, explain to the extended family that she is depressed and needs help and support, but the diagnosis needs to be made, and that the family doctor can do a lot to help with.
Mm-hmm. And I know when you're treating women during pregnancy or that are breastfeeding, you use a benefit versus risk ratio, right? So tell me, when would you decide to encourage a woman to start medication versus maybe not?
So I think that if someone has a postnatal depression and it's moderate to severe, that's a time to think about medication. I think that we have medication that is safe in breastfeeding. Moms can be encouraged to take it. I think if someone has mild to moderate postpartum depression, cognitive behavioral therapy is effective in managing that, and attending a cognitive behavioral therapy group or one-to-one counseling can work. I think if a mom is depressed in the pregnancy, there is a window we have for the initiation of psychiatric medication for a depression. So if a major depression is diagnosed in the first trimester or before pregnancy, or in the second trimester, we can give them antidepressants at that point. We cannot start antidepressants in the last trimester of pregnancy because that's a risk to the infant. And so for the risk benefit assessment, it would be if a mom's sitting in front of a family doctor and they can see that this mom has had a family history, previous episodes, and has already started to develop symptoms of depression in the first trimester, that's a mom to think about antidepressants. The benefit of starting it in pregnancy is that you can start it at a much lower dose and you can prevent the postpartum depression, and then the mom doesn't have to stay on antidepressants for a long time, and you can combine it with CBT for the best possible outcome for the mom and the baby.
Great. Well, thank you so much, Dr. Levin.
Thank you, Tammy.